Today we will be discussing, just watch.
In this video, I will cover urinary incontinence in women. I will talk about types, diagnosis, and treatments. If you want to support this channel and see more videos like this, please like and subscribe. Hit the bell button to be notified, and let's get back to it. There are many types of urinary incontinence. However, the major ones that I will talk about today are the urge incontinence, also known as the trousseau overactivity, and stress incontinence. History is the most important part of diagnosis. If the patient gives a history of incontinence while coughing or sneezing or during physical activity, most likely she has stress incontinence. But if the patient gives a history of frequent and nighttime urination and unable to wait for long when she has the urge to void, most likely she has urge incontinence. It's also important to ask about the timing of incidents, the amount of fluid intake, and whether she drinks any caffeinated drinks, drug history, and any previous surgeries for urinary incontinence. When assessing patients, 4 important things need to be done. First, urine culture to rule out an infection. Second, post-void residual. This can be assessed by an ultrasound or a catheter after voiding. Third is a cough test to assess for the presence of stress incontinence. And lastly, urethral mobility by a Q-tip test. The urethra is considered mobile if the Q-tip moves more than 30 degrees. Management of urge incontinence starts with conservative measures. Bladder training by gradually decreasing the frequency of voiding, limit fluid intake to 2 liters per day, weight loss, and avoiding caffeinated drinks. If the conservative measures do not help, then we can start with medications, and they can be divided into 2 categories. First is antimuscarinic drugs, and the second is beta-3 agonist. Although used to be considered a second-line treatment, now intravesicular Botox injection is moving to be a first-line treatment for urge incontinence. Topical estrogen can help with some cases of urge incontinence. Neuromodulation like sacral nerve stimulation is now considered a second-line treatment with unknown mechanism of action. It's done in 2 steps. The first is electrode placement, and if the patient experiences improvement, then the second step is performed, which is implantation of a pulse generator. Treatment of stress incontinence also starts with conservative management, although surgery is an acceptable first approach. Conservative treatment includes bladder training, pelvic floor exercise, and inserting a specialized type of incontinence pessaries. Pessaries are effective if the patient is not a suitable candidate or wants to avoid surgery. Surgical treatment involves inserting a midurethral sling to support the urethra and prevent stress incontinence. Injecting bulking agents around the urethra cystoscopically can be used in case of recurrence of symptoms after surgery, older patients who cannot tolerate more invasive surgery, or in case of symptoms with a non-mobile urethra. The procedure needs to be repeated.
For videos like this, like and subscribe.